I have with me Dr. John Bowie, a prosthodontist, a Texas A&M graduate. Uh, Somebody's waving. And has his own practice in Midlothian. He does his own lab work, so he's a hands-on type of prosthodontist. He's here with us this morning to share his own cases that he's been doing in his practice. It's going to be a mix of fixed and removable. And the next 2 hours will be a lot of fun and a lot of stuff to learn. So I'm going to pass the mic to Dr. John Bowie, and please give him a warm welcome. Thank you.
Okay. Thank you, Ely, for the introduction. And if I'm speaking too softly, y'all just let me know. But it's a real pleasure to be here. I've been really looking forward to coming and speaking and sharing. And I just want to start off by saying that I'm pretty much, my mindset, I'm a prosthodontist, but my mindset is with you guys. I think probably primarily. I think of myself more of a technician than I do as a clinician sometimes, but I wear all hats. So I wear the surgeon's hat, I wear the clinician's hat, the prosthodontist's hat, and then I also wear the technician's hat. So I'm doing a lot of my own work, and I really enjoy it. So it's a lot of fun, and that's what got me into pros. Originally wanted to do pediatric dentistry, but they don't do any gold in pediatric dentistry, right? So that's what really got me interested in maybe thinking more pros. And then by the time I was a second year dental student, I was helping with the free clinic that we had there in California where I went to dental school. So that really just cemented my love for prosthodontics. So I'm really happy to do what I do, and I have a good time. So a little bit about me real quick. I grew up in Fort Worth, Burleson, Fort Worth. And then I went to Pepperdine in 2008, and then stayed in California. That's in Malibu, California. And then I stayed in California for dental school at Loma Linda University. Very pros heavy, got an excellent education there, and then came back to Texas in 2016 to do pros at A&M under the direction of Dr. William Nagy and Dr. Aaron Cho, who's the director now. So I had a bunch of really good mentors when I was in pros and in dental school. And then I immediately, once I finished my pros residency, immediately started my practice in Midlothian. So a little bit about me. I have my lovely wife here. So we've been married for 2 years, and I like to do outdoorsy things. I like to hunt. I'm like the hunt and fish guy, and we like to go to lakes and such. We have a 1-year-old son, James, and we like to do mission work as well. This is actually in Nicaragua when I was in dental school, but I like to do mission work. There's a lot of local opportunities in the Metroplex to get involved with. So really think that's important to give back. And so I, like I said, dentistry is a really great tool to help other people. My areas of interest. So I like to speak. This is actually a picture at the dental college, speaking in front of the technician group. So that was a lot of fun. That was when I was still in residency. Like implants a lot because they solve a lot of problems. Like doing hybrids, full arch fixed restorations. They're a lot of fun. I just think a lot of what we do is just a lot of fun. And so I can't believe that like people actually let me work on them, because it's more fun than it is work. So I just really enjoy what I do. Crown and bridge, full mouth wax ups, full mouth rehabs. It's just like straight pros. I really love what I do. So I'm getting more into the printing game. So we got a printer when I was in residency. So I have 3 in my practice. And it's just like every couple of months, the printers have babies and they beget more printers. So it's like, once you get into kind of the digital game and the digital world, it's really fun, and you see how much time and effort it saves you. So it's been a lot of fun. I've been in practice for a little over a year, and just really love it down there. So What the prosthodontist does, it's the guy who wears a lot of hats. I have to know, I'm a clinician primarily, right? And so I see patients 8 to 5, every day for 4 days a week, and then sometimes on Fridays. You have to be a material scientist. You guys are as well. You have to know your materials. You have to know how to handle them. You have to know how to work them. And I'm going to talk a little bit about that this morning. You also have to be a public figure, right? When you're a specialist or when you're a dentist or when you're a technician, people are going to be looking to you for answers, and they're going to be looking to you to help them and help them help other people. I like to think of myself as a workflow engineer too, because you go to the conferences and you see the before and after pictures, but what sometimes doesn't get said is, hey, how did you get from point A to point B? Like, what all did it take to get from this where we started to where we finished? And so I'm always tinkering with my workflows, sometimes on the fly, which I've got some neat things that I'll show y'all here that I just did on Thursday as it pertains to hybrid restorations, fixed detachable. And then obviously laboratory technician as well. So even if you're sending out, you still have to do QA, and you have to check, and you have to make sure that what you get is what you want. And so if for me, I'm doing a lot of my own. I'm doing my own removable. I'm doing my own fixed designs and everything like that. And then obviously as a surgeon as well. So I do place probably 60% of my own implants. We have a really talented oral surgeon down the road, Dr. Quentin Slaughter, and then a couple of good periodontists. So there's, I don't do all of my own surgeries, but I'll do a fair amount. So it's a lot of fun as well to place implants. And then, this is just showing kind of some other areas that I'll talk a little bit about this morning. Partials, still a place in practice today, or overdenture frameworks, and then full mouth wax ups that you can effect into reality with a 3D printer, crown and bridge on implants, printed provisionals, which I really, really like to do because it's basically like an assistant making your temporaries for you. So when I'm doing like a full arch prep day on natural teeth, I'll prep all the teeth and I'll show you the workflow. And then basically I go back, patient takes a break, they take a nap, and I go back and sip on a coffee and let the printer do the work for me of making the temporaries. So, and then obviously doing conversions here. So that's another big part of the practice. Trying to ramp up even more is doing full arch fixed. So doing conversions via surgery. Really like to do that. It's brutal because it's a long day. If any of y'all have ever done any conversions, it's a lot, but it's a lot of fun. So I have my presentation split up into two basic parts. We're going to do removable prosthetics first. I'll talk about that, and then we'll talk about some fixed cases. So I want to just start by saying, and iterating to y'all why removable is important. When somebody comes in, they don't have any teeth, you have to know where to start, right? You have to know how to basically build up somebody from scratch. It's building something up from the foundation up. And when somebody comes in, they don't have any references, they don't have any teeth for you to kind of go by, you're doing everything from scratch. And you guys that have done any removable know this. And so it really forces you to have an eye for aesthetics. You have to know and understand vertical dimension. You have to know and understand your aesthetic references. You have to know and understand repose position. You have to understand your 8 and 9 position, your buccal corridors, your occlusal contacts, the fit and stability, and the materials. There's a lot that goes into just making a denture, right? And so if you're going to be doing, as a clinician, if you're going to be doing fixed cases like full mouth rehabs and hybrids, really removable is where you start, right? Because that's going to give you the eye for doing everything. And the only difference really, when you really think about it as far as aesthetics and contacts and everything is concerned is that it's your occlusal contacts in the anterior, right? That's the main difference, right? You still want the same kinds of contacts. It's just a little bit swapped in the anterior, removable versus fixed. And so whenever I do my removable, I'm doing the full 5 appointments. I'm doing preliminary impressions, final impressions with custom trays, interocclusal records, try-in appointment with teeth, and then the seating appointment. And one thing that you won't see on that slide is what comes after the seating appointment, because you can't just give somebody the dentures and let them go, right? You need to do proper follow-up and maintenance, and that's really important as well. So these are all cases that I have done myself, where I set the teeth and I process. I use an IvoBase in my practice, which is awesome. I love that machine because it saves me so much time. And if you look at literature comparing heat pressed or heat packed versus IvoCap versus like IvoBase, an injection system, you'll find that the injection systems are just so much better. You have less volumetric and linear shrinkage by a factor of like 10. So the IvoBase has been really great in my practice, and I really enjoy using it. And so these are a couple of removable cases, and these are a few more. So I really like, and photographs are important too because they tell a story, and you can tell, kind of a patient's personality. And I really spend a lot of time trying to match patients' personality and kind of match who they are with the setup and with the teeth. And sometimes I'm doing more than one try-in. If I really want to tweak something, I'll tell the patient, just come back in a couple days and I'll have it ready for you, or I'll just sit there and do it chairside. That's the most fun, is whenever you do a setup kind of chairside and tweak some things, because patients don't really get to see that. So I think that's very important for us in practice as well. And it saves the headache of logistically sending a case back just to tweak a couple of things, right? So it really helps with efficiency. And as far as like what I'm all about too is consistency. If you guys have not read these Rudd articles, they're kind of old, and they pertain to partial dentures. But basically, Rudd came up with 250 ways. I think he's from San Antonio. 250 ways that you can mess up a partial, right? There's so many different sources of error when making a partial denture. And the same applies, you think about how many moving parts there are that go into that. That's pretty much true regardless of what the indication is and what your treatment is. There's so many different ways for things to go wrong. So consistency is very important. That's the bottom line of his articles. Whether you're measuring stone powder ratio, the powder to water ratio, or pouring up your impressions correctly, there's a lot of different ways that things can go wrong. And so the important thing is to be consistent with what you do and find something that works. It doesn't matter which workflow you use. You guys are old enough. Hopefully nobody's not still using polysulfide. But if you're old enough, you know polysulfide, right? It doesn't matter if you're doing green stick compound or VPS for your border molding, and then a wash and VPS or polysulfide. It doesn't matter. As long as you know how to use your materials, and as long as you know what you're doing, and keeping it consistent, you're going to have good, consistent results. So this is this is what I like to do in some situations where I'm a little bit uncertain if I'm going to have a good result just with something that's removable. I'll actually go and process a record base after I pour up my final impression, and then check all the extensions, the border extensions, check the seal, check the fit of everything, and then I'll proceed. This is really useful on mandibular cases whenever you don't want to wait till the end to know if it's going to fit well and the patient's going to be happy. So on my end, I can get something back at the third appointment, right? At the interocclusal record appointment, at the wax rim appointment, you have your wax rims sitting on top of these pre-processed record bases. And one, it's going to give you a better interocclusal record, and then also it's going to set the stage in the patient's mind for, hey, is this really going to work? Because if you put that in and it starts floating around, the patient knows you've just made a really good impression at that previous appointment, right? But you start to dial in on the patient's expectations and the patient's goals at the third appointment instead of at the very end. So if there's any question, I like to do these, especially on the mandibular arch, where you just do you can do this with whatever processing system you want, as long as you do it, right? So you can check your borders with a little disclosing wax, and you can make remount casts here with a little bit of putty and then a stone. That's how you mount with these, and then those are your working casts there. So this is a case I did with Fanaris teeth. Turned out really nicely, and it was really fun because this patient was seen in the predoctoral clinic, and she wasn't happy with her mandibular denture, as most people are not. As we talked about yesterday, you get about 10 to 20% of your bite force, and there's no stability. One of my friends, he told me a really good way to think about it and talk to patients. There's three F's when it comes to dentures. You can have a fixed denture, you can have a flexing denture, which is an overdenture, and then you can have a floating denture, which is with nothing. So I actually use that when I talk to patients to kind of give them a quick breakdown. So this patient was not happy with her mandibular denture, so I said, let me make you a new set that fits really well, that's well adapted. We'll see how you do. What I typically do in my practice is I'll let these patients go after we've got sore spots adjusted. I'll let them go for 21 days. That's what science says it takes in order to uh, start or get a new habit, right? So to get a new habit and to get used to something, to accommodate to something new, science says about 21 days is where you want to go. So I tell the patient, hey, look, try this out 21 days, then you come back and we'll start talking about implants. And that's what this patient did. And that's what we did with her. So she came back. The maxillary denture was perfect. She loved it. It fit well. It was well adapted. Mandibular denture was not where she wanted, and she wanted to have it. So we did that, and she healed. And I typically will do just a little bit of soft liner. I use tissue conditioning typically at the time of surgery, wherever I'm doing a surgical procedure. And then I'll do about 2 weeks later, I'll go ahead and do a more of like a long-term soft liner. And that usually gets us through about the 3 months to the time that the implants are ready to uncover. Whenever you place implants for overdentures, you want to try to bury them. It's kind of a hassle for the patient because they have to have another surgery. But you really want to bury them because you don't want to be the patient. If you ream out the denture on the inside, if you put a soft liner on, if you do nothing, the patient's going to be putting pressure on those implants, which is exactly what you don't want to do. And so when I'm placing overdenture implants, I will bury them and then come back in and uncover them later. So what I like to do too is my anatomy everywhere else is correct, right? I have my final anatomy except for in the anterior mandible. So what I like to do is I like to do a hard reline chairside, and you can do this in one go if you wanted to with a hard reline material. They make a lot of really good ones. I actually decided to do this with some high flow from Triad, some Triad high flow, and it has a primer. And basically, what you do is you roughen up the inside of the denture, and then you adapt it in the intaglio. It's a really nice, and it hardens up really well. And then you light cure it in the mouth, right? So you come in and out a couple of times, make sure it's well adapted. You light cure it in the mouth, and then you take it to the laboratory and cure it in the VLC unit. And then you bring it back to the mouth, put your locators on, torque them down, and then you can start doing your reaming procedure here. So there's a really nice burr kit from Zest that has a locator burr in it that's a circle. That's a perfect size for this. Also, as a side tip, that Zest locator burr is perfect when you're doing hybrid conversions and you need space for your temporary copings. So just as an FYI. But you use a little VPS. I use bite registration. You can use something like a fit checker, and then ready to process in the housings. It's best. There's a ton of different ways to process housings, as discussed before. Doing in the mouth is best. And a pro tip would be actually, you can't do this on maxillary palataless overdentures, but a pro tip on a mandibular denture is to let the patient go home without picking up the implants and come back the next day. Because what's going to happen at that 24-hour recall, you pick up the implants at 24 hours because there's a settling effect on the basilar surface, right? So when you have a stone model, the stone model is not compressible, but the tissue is. You can have compression up to 1 millimeter or more in the soft tissue, right, depending on the gingival thickness. And so if you let the patient go home for 24 hours, the basilar surface of the denture starts to settle in, and then you get a little bit more of an adaptation, and then you don't have as much flexure whenever you pick up your locators. So that's a pro tip to tell your doctors, hey, when the patient comes back at 24 hours, that's whenever the ideal time is to go ahead and pick up the inserts. And so you'll have a lot less flexure on your implants and flexure on your prosthetic components and flexure on where you did your housing pickup. This is another situation. This lady, she was edentulated. She lives up in, I think, the Sherman area. Very sweet. She was edentulated like 10, 12 years ago. Had a couple of implants placed. Maybe even been longer than that, actually, because these are Brandemark external hex fixtures with abutment cylinders on them to bring up the platform right for this cast bar. And so she came in to see me with a temporary and an immediate denture that just had bite blocks in the back. And so I said, okay, whatever we decide to do, it's going to be better than what you have. But she had a denture, and as you can see here, this is where she smiles, right? And she was actually biting on the bar. That's how she ate. She didn't have a mandibular denture, overdenture. She just had the bar. There was way not enough space for this type of prosthesis. So in order to make things simple, and that's what I like to do in my practice, I like to keep things simple. That's why I was asking Chris yesterday, about the different heights of those cylinders, right, from Preet. I said, why not just buy the one and cut it down, right? Keep less inventory, because we have to keep up with enough stuff in the laboratory. Why not keep your inventory simple? So I like to keep things simple. And so what I did was I just went ahead and converted her to stud type attachments. So this is showing her maxillary arch. Once again, the processed record base. No surprises there at the third appointment, at the interocclusal records appointment. Very happy with the fit of this. And it's kind of funny, there's no teeth, and you put wax rims, and I'll sometimes make my wax rims chair side, right? But you kind of put these in, and they just kind of float up into place, and then they stay. So it's kind of funny seeing just a processed record base by itself, just staying in the mouth. But that's that's the fun part here. And on the topic of vertical dimension, which was not addressed properly in this case, that's something that I'm always very, very keen on, right? And so it doesn't matter what you're doing, fixed over fixed, removable over removable, removable over fixed. It doesn't matter what you're doing. Dentate patients, your vertical dimension is extreme importance. And what I do whenever I'm evaluating a patient when they come in with whatever they need to have done, I'm usually using my tongue blade, and I'm making some markings on that tongue blade, and I'm putting dots on their nose and on their chin, because I want to see where they're at. I want to see where their musculature is at, and I want to see if I can open their vertical and if they're collapsed. Because with a dentate patient, there's a whole classification system called the Turner classification, where it gives you different indications based on what the patient presents with natural teeth. There's a whole different slew of ways that they can be collapsed, and you have to know, especially with fixed, you have to know how much you can open that patient predictably. There's a bunch of different ways to do this, and they all go back they go way back. Nishwanger is the classic, and Silverman is the other classic. That's the swallow and rest. And he calculated, this is where you get your 3 millimeters of difference, right? When you go to VDR versus VDO, that's the 3 millimeters. That's from Nishwanger back in the 30s. But Silverman, he talked about closest speaking space, which is basically saying yes and holding the hiss, holding the S. He found that there was about a 1 to 2 millimeter difference measured at the premolar whenever you do an S sound, because the teeth don't touch whenever you say S. Lytle, and I hear the hissing. No, the Lytle. So Lytle was they did a Gothic arch, which is they would basically kind of dial in and dial up and dial down with a Gothic arch until the patient felt comfortable. Olson, that article is really fun because they literally took a coat hanger and bent it to fit the patient's profile before extractions. And then they would use that for the vertical dimension after they started fabricating the final dentures. So it's like you see in this article, this guy holding a coat hanger outline of someone's face. There's other good ways to do it. Phonetically, you have them say M and hold the M, because that gets you to about this 3 millimeter position there. But really the best way is just to do multiple ways. And then I kind of take an average, right? So if I'm getting, if I'm at like 1 or 2 millimeters off, depending on the method that I use, I'll just put an average, and that's an average, right? Because whenever you make a record, an interocclusal record, it's just a starting point, right? Your final vertical dimension is set when you seat the prostheses, right? That's your final vertical dimension. But everything that you start with, interocclusal records, that's just a starting place. And of course, as far as vertical, occlusal plane makes a big difference as well. So Lundquist, 1970, the ultra classic article, the occlusal plane very closely actually approximates the retromolar pad. So if any of y'all are used to getting these wax rims that look a little funny, and you say, okay, the wax rim that I get since going away, if you're doing a setup based on anatomic averages, it's very nice to just do about 2/3 up the retromolar pad, like that's classic, right, for your occlusal plane. And then what also follows the occlusal plane, natural occlusal plane, is, according to this Karzakis, which is a Greek author, it very closely approximates the ala tragus line. And so that's where you get, that's Camper's plane, right? So that's what I usually try to follow clinically whenever I'm developing the occlusal plane. And so I'll sometimes take these, if there's some question here, I'll take a Fox plane, or this is actually the Fox plane that comes with the dentofacial analyzer, the Koisbo. And so I won't even put the white jig transfer jig on that. I'll just put this in the mouth and just take a picture or look at it and make sure that. Funny, Karzakis, he went so far, so picky, that he found that it was actually closely approximates the upper 2/3 of the tragus, right? He divided the tragus into thirds. It's like, man, I don't know how you measure that, something that small, to get that precise, but they actually found that it was like 2/3 up the tragus was the occlusal plane, what it most approximated. But I always take photographs at the tri-ends, at the wax tri-end, because there's always something that you want to tweak. This is going back to the lady that had the bar that I took off. And so I wasn't quite happy with the buccal corridor here. And then also she had a hyperactive, some hyperactive lip muscles here, some elevator muscles on her lips. And so she actually kind of had that Elvis snarl a little bit. And so I'll show you all a little bit of literature here in a second, but I wanted to follow the lip line, the smile arc. So I took the bar off. Luckily, it was screw retained. I took the abutment cylinders off, and then I was at the fixture level. So I ordered a couple of external hex Brennemark locators after I measured the gingival cuff height. It's very important to measure the gingival cuff height at the highest portion of the gingiva, because that's where your locator is going to stick up right the most, but that's where it needs to be. That's the deepest part there. So if I measured the gingival cuff height here, 1 millimeter, maybe 1.5, I'm going to have a locator that sits below the gingival margin here, and that's going to be either A, it's not going to fit whenever you do your pickup, or B, it's going to be very uncomfortable for the patient. So whenever I'm measuring these, I'm measuring the thickest or the tallest portion of the gingiva there. So that's that's what I do. And sometimes I'll take a picture because I'll forget, or I'll call it out to the assistant. So have a system in place. So this is the final result here. This is with blue line teeth, and this lady turned out, it was very nice, and she was very pleased. And this next photo. This photo here, she has that hyperactive lip. And so whenever you have a discrepancy in basically the lip position or the muscle activity, or if their eyes, which doesn't happen very common in nature, right? We're usually, sometimes what we're doing is we're following a line that's parallel to the eyes to get our 8 and 9 position. But sometimes, very rarely, the eyes can be a little bit off due to developmental aberrancies. Um, with your incisal plane needs to follow something. And this author here, this Sharma author, they did a systematic review, or he was featured in a systematic review that's a little bit more recent from Del Monte, 2017. But Sharma said the incisal plane, as developed here in the anterior, so that's canine to canine for me, it should follow the curvature of the lower lip when a discrepancy is present. So they had lay people come and evaluate different setups and arrangements and photographs that had been digitally manipulated, and they found that, you know, when there's some discrepancy there, when the lip is canted or when the eyes are canted, it's best to follow. You know, you want your anatomic structures and your teeth to kind of follow each other and to have flow. So they found that when in doubt, follow the lower lip curvature. So this is another patient that came to see me. This was in residency. Very successful, actually, but just completely negligent. And so this guy, we told him, I mean, everything's got to go. Rampant decay, rampant periodontal disease, you know, weird things that we almost had the pathologist look at, you know, but I mean, it was just a total disaster. And he said, I'm ready. You know, I'm ready. I've been putting it off. I'm ready. And that's when you got to really jump on and really help these people out, is when they're ready, right? So you don't want to sit around and wait around to help these guys. So I turned around a quick set of immediates. And then what I do is I duplicate. And by the way, we went for the mandibular hybrid after talking about the options. We elected to start off with a removable appliance on the maxilla, but when we took the teeth out on the mandibular arch, we wanted to go ahead and place implants for fixed. And so what I do is I'll just duplicate the dentures that I'm going to be using for surgery. And this is an actual pencil. It's a surgical pencil that comes sterilized, right? You put it in a pouch and sterilize it, and you can mark on your bone where you want your reduction to be. So for this patient, we reduced 15 millimeters measured at the incisal edge down to the shelf, right, the bony shelf, and that's where we started placing our implants there. And so this patient went home with some immediates that I put a tissue conditioner in. Like I said, I'll come back in 2 weeks later and do a soft liner, and that helps the patient out comfort-wise. And then he went with his mandibular denture. So he came out looking perfect. So this is the day of surgery, you know, and these patients are not, you know, they're not doing too hot when they come out of surgery, but you help them through. And that's my job as a clinician. Hey, I'm going to take this soft liner out. I'm going to redo it. Sometimes I'll even print a denture. You know, if it's kind of off, you know, and I really want to make sure, you know, that the patient's comfortable, I can print a denture for almost nothing and give it to them and reline that in the mouth. And then that's what they go home with for the 3 or 4 months for healing period. But he healed up really nicely. He came back and we did the uncovery, and I did a thermoplastic sheet on top of the denture that he had, right? So I just took this to the lab and did a quick little, like a copyplast, you know, and then I put it in the mouth, and that's how I got my multi-units where I wanted them to go. You know, you don't have to duplicate the denture just for the placing the multi-units, right? So that's how I got these multi-units to place. Then I did my final impression on my maxilla and my mandibular arch. So just a little green stick compound. I'll do this with VPS nowadays, but a little VPS wash. You can combine, you know, green stick with VPS. It's really nice. You just have to cut it back about 0.5 millimeter on the periphery. And then on the my hybrid impressions on the mandibular arch, what I like to do is I like to, it's kind of fun. So what I'll do is I'll put the impression copings on in the mouth, right? They're not splinted. And then I make a little slip knot with some floss. and I'll start tying. I'll tie these around, dab a little bit of triad gel, which is really nice. It's less expensive than flowable, and it's a little bit more rigid than blockout resin, and it's a little bit more flowy. You know, it's less viscous than blockout resin. So I'll make these jigs in the mouth with triad gel, and then I'll come in with a high-speed handpiece and section them between the implants, and then relute them with the triad gel. And the reason for that is because with any type of light curing or auto mix resin, you're going to have shrinkage, right? But let's say you have 1% shrinkage. So if you have 1% shrinkage on this whole segment here, it could be significant, right? But whenever you cut between the implants, your shrinkage goes away, right? It rebounds. And then whenever you relute this in the mouth, now your 1% of shrinkage is like from a millimeter. You know, it's 1% of a millimeter whenever you relute those together. So that's how you get really close at your final impression here. And then obviously you go back in and you do your verification jig, and then remake the impression if you need it, right? But what I like to do with my verification jigs is I like to make them in the lab and then transfer them to the mouth, and then lute them back together in the mouth, and then look at it on the cast. Like it's hard for me to visualize in the mouth, you know, patients moving, can't really see multi-units or equigingival or something, right? So it's hard to see that in the mouth. But if you make the verification jig in the mouth, or if you lute it together in the mouth and then transfer it to the cast, that's just a lot easier to me. So you can look at it, you know, take the gingival mask off, take a look at it, make sure it drops on. And when you make your final impressions like this, I mean, I haven't had any issues with things not fitting. When you make them like this, when you make your final impression, you know, from scratch in the mouth like this, cut it and relute it. So, and then I designed the bar, have it come back. This is the hygienic type bar, right? This is the Montreal type bar, where you have the metal belly. And then what I like to do is I like to anodize these, and so I don't put a lot of opacers unless it's my acrylic's going to be really thin. But I like to anodize these, and I like to anodize them gold, because gold, according to literature, and you can do this in pink as well. Has anybody ever, y'all have anodizing machines? Anybody? So the anodizing machine that you buy off of circuitspecialists.com is $100. When you go to do this, when you get this back, you need to clean it in like acetone or some sort of an organic solvent, right? Because your fingerprints are on it, and make it exceptionally clean. And then you dip this in. When we first got the machine, I kid you not, we used Diet Coke as the electrolyte. We poured Diet Coke in a glass beaker, dropped this thing in, and that's what you get out. There's a little bit more sophisticated ways to do it than Diet Coke. TSP, trisodium phosphate, it's an electrolyte. There's nothing fancy. I think you could probably use salt water if you really wanted to, but there's a really good article by Wadwani. He's up out of UW, and that, you know, you can anodize custom abutments, you can anodize your bar frameworks, you can anodize, as long as it's titanium, you can anodize it. And on the voltage, it's around 60 volts, 60 to 65 volts is what you want to shoot for. And it's actually better than pink. You know, you see the option for pink anodizing. Pink anodizing still gives you a little bit of a darker tinge in the mouth, especially subgingival. So gold anodizing, according to literature, is the best to use for anodizing. So that's what I like to do on all of my titanium. You know, and then you make your measurements, occlusal vertical dimension, nice wax rim. This is for a different situation here, but I wanted to throw this in here. This is what I'm doing now. I will actually design a bar on Exocad and then print it. And then I put a little bit of Teflon tape over that bar and then make a wax rim. So what I can do in the mouth is I can place this bar in the mouth and, you know, put one screw or two screws in. That's with the DES library. And then I basically have a wax rim that comes in and out. It's very easy. You don't have to unscrew the whole thing, screw it back in every time you're making. As far as your occlusion is concerned, there's a very nice article by Kim that's around the I think 2006, where it talks about what type of occlusion you want opposing, like what opposes what on the occlusion. And so for something like this, what you want to do is you want to favor the least retentive arch. So for this, we have our rigid implant support on the mandible, but on the maxilla, we don't have any implant support. And so what we want to do is we want to set a traditional lingualized occlusion. We want to have a little bit of space in the anterior, 1 millimeter, horizontal and vertical space. And we want to have lingualized contacts because that's going to help our stability on the maxilla. This is another patient here. This is why occlusal plane and incisal line is so important. She had a denture from somewhere else, and she couldn't wear the mandibular denture at all. She was actually like, I think, early 40s, but she came in, doctor, my husband won't kiss me. I look like I'm 70 or 80 years old. I mean, she was young, right? But she had the classic, witch's chin, right? We know from Tallgren's article from the late 70s, that the mandible, the pattern of resorption in the mandible makes you look like this. And she'd only been a dentulous for a couple of years. So she was in a poor place there with a denture that was basically set flat. And this is what you see a lot of times, right? This is what I see a lot of times. Patient comes in, they have a denture where it's completely flat. So it's like basically, what you do is you set the occlusion flat and on a flat plane, and that's it, right? There's no occlusal plane on this developed that was parallel campered. There's no incisal plane here, and so that's where I try to do things a little bit different. When you're mounting on your articulator, when you mount with a face bow or when you mount with some sort of a mounting jig, you're making a relationship. So I have to ask, rhetorical question: what's the purpose of the face bow? There's two purposes of the face bow. The face bow relates your maxillary cast. First of all, it's a way to mount. But in that, it relates your hinge axis position to the maxilla. We know from research that the face bow, if it's within 2 or so millimeters of the hinge axis position, it's going to be almost dead on at the teeth, right? So thank you for the clapping. So your hinge axis, there has to be a relationship there, right? When you use something like Bonwell's triangle, that's an anatomic average. When you use a face bow, that's an anatomic average, right? Because the external meatus has a close relationship with the terminal hinge axis position. That's why you use the meatus. I usually use an anatomic average. I'll use something like Bonwell's triangle with a flat mounting plate, but I'll show you why here in a second. And then the other thing the face bow shows you is your aesthetic references. It's going to relate the maxilla to some aesthetic reference. With a face bow, that's typically like your McNamara line, or it's going to be a Frankfurt plane, right, which is developed from orbitali to the meatus, which is going to be basically a relationship with the horizontal, right, with the horizon. And so when you mount, and your aesthetic references based on that cant and occlusal plane, right? But when you mount, as long as you're intentional with what you do, I don't think you need a face bow in most cases. And the reason why, and I'll show you why that's true in some fixed cases, but you have to know, like, it has to be spot on with what you're doing, and your workflow has to be very intentional. But what I typically do with my articulator, and I use the Stratus 200, what I'm typically doing is I'm using the flat mounting plate. And the reason why is because when I do a wax rim, I'm developing to Camper's line in the mouth. I spend a lot of time in the mouth developing my occlusal plane and my occlusion rim. And so when I mount on the articulator, I'm mounting parallel. This is flat, right? So this is mounting parallel to the upper member on your articulator. And so what that tells me whenever I'm doing my setup is as long as I'm setting my teeth flat on the articulator, parallel to the horizontal, right, to the maxillary member, I'm going to have developed my occlusal plane in the mouth. Even though it's flat on the articulator, we're going to have that occlusal plane that we're looking for. So that's a little way, and like I said, with consistency, as long as you develop a really nice camper's plane in the mouth, you're going to have a nice setup on your articulator, as long as you know what you're doing. The other problem I have with the face bows is the SAM face bow is really good because it has one screw, but with these face bows where you have all these moving parts, like I said, red articles, very easy to get off track, very easy to over tighten. You'll see this a lot, right? I'm sure with your face bows, it's easy to tighten up too far. And when you tighten, that whole thing will tend to cant in the direction that you're tightening. So if you get something back in a face bow and it looks like this, it's probably because it was over tightened in the mouth on the set screws. Anyway, this patient was class 2, and you can't ignore the aesthetic references on the maxilla, but you also cannot ignore the skeletal differences there. So Goyle in the late 70s or early 80s had some really nice articles on how to do a full balance setup on a class 2 patient. I don't follow all of those exactly because I'm usually doing lingualized, which is a little easier to set. But if you have a class 2 patient, don't try to set them in a class 1, right? Because they're going to posture forward anyway. So when I have a class 2 patient that comes in, I'm going to set them up in a class 2. Sometimes I'll cheat it a little bit, but you really can't ignore what nature gives you, right? If you do, you're going to have issues. And so we do the setup and then bring it to the mouth, and we give her something in the repose that looks more age appropriate, and then something where we have a nicer incisal smile mark. I'm going to talk a little bit about overdentures for a second. Love doing overdentures. This is at the half flask. This is with a really nice lady who lives in the same town, which I practice. She had an overdenture that was palateless, but it didn't have a metal framework. Those break, right? And that's a remake after, it could be a couple years, it could be 2 months. Palateless overdentures that don't have some type of reinforcement break. The nice thing that we have access to now is you can make a really nice printed chrome cobalt framework, and it doesn't cost an arm and a leg. There's a company out of New Jersey, they're really out of Canada, it's 3D RPD. 3D RPD, you send them a cast, you send them a scan cast, you send them a design from your design software, and they'll print it and send it back to you. And it's really not that expensive, and they fit like a glove. And so that's what I used in this situation here. You need to have an external finish line with a millimeter butt margin for your acrylic. And I usually like to go, I think it's like 7 or 8/10 of a millimeter of relief on top of here, just in case I need to reline or something later. And then you need to make sure to have at least a few millimeters away from where your housings are going to be, right? Because what you don't want to be doing as a dentist is, hey, can you go, to your assistant, hey, go get me the high-speed handpiece, and start to burr out the metal here, right? Because that's going to take you forever. And so these are really nice, and you can develop these to where they're really pretty high and tight up off of the palate, and they work really nicely. I'll usually score do a 0.5 millimeter score at the external finish line here on the palate. And if I have to bring that back a little bit, a little rubber wheel does the trick in the mouth. So, but these are really nice, and they fit well. Just showing a little bite registration here to do the pickups, and that's the final result. And you can see that this metal here, this is flush with the, there's an internal finish line as well. And so the metal here with the palate, and that helps with the seal. But like I said, I'll usually do a 0.5 millimeter score line where I want the framework to end. This is this is a really interesting case that's still ongoing. This gentleman came in, his maxillary sinus, for whatever reason, comes up to the canine. It's highly pneumatized. So the oral surgeon down in Cleburne, he was able to sneak an implant here. This is basically the number 6 position. The local dentist there made an overdenture that, quite frankly, I wasn't a fan of, but I met with her and talked with her and went over some of the challenges. And this was very challenging for her, because this gentleman, when he bites and when he chews like, there's 2 types of patients, right? There's the rats straight up and down, and then there's the cows, right, that are side to side. This guy is a cow on steroids. When he's like, yeah, my normal bite, and his mandibular jaw is it's all the way over, like 10 millimeters on one side. So this guy, he had no support. The fulcrum line on this overdenture was here. And so every time he would bite down on this side would lift up, right? So this was not a good situation. This is not an appropriate stud type overdenture patient. And so what I did was I said, hey, look, let's try this first. Let's try an overdenture first and just see. We'll make it palateless. That was another huge complaint, was we needed to get rid of the palate. Couldn't taste his food. So I made him a nice, slim, palateless overdenture. This is showing the design from 3D RPD. Very nice design there. And he was very happy with that. However, I had to use the strongest inserts in the mouth on that number 6 implant, and also on the number 11 implant, because that's where the fulcrum line was. And it's okay, but it's not quite what I wanted for him. So what I actually did for him, and this is, like I said, this is still an ongoing case, is I wanted to make a Marius bridge. And so you can, on Exocad, you can actually design these, and they're really easy to design. I use a double structure, so a substructure and a superstructure. So the substructure is designed on Exocad. You have a 4-degree taper on the bar, and the insertion axis is 25 degrees to the facial. And that helps, that way the patient doesn't have to put this thing in all the way and then go up. The insertion axis comes from like this, right? And so then what I did for this, instead of doing tap locators, because I didn't have the space, I designed in the bar some side holes for doing the pins. So the plunger lock pins, right? What Chris was talking about yesterday from Pre. And these are identical to Swiss lock, but they're a little bit easier to service. And so the bar comes back, I put the powder on, I scan it again. What I really don't trust quite yet is doing a split file on the computer. So sometimes what you can do is you can save your bar STL file related to the jaw scan, and then you can make your superstructure at the same time as you make your bar. I don't quite trust that at this point. So what I do is, and it takes extra time, it's fine. You get your bar back, and then you scan the bar, and then you make a superstructure that fits on top of the bar. So that's in the mouth. I tried this in, to make sure where we need to go here with the superstructure is appropriate, and then that's ready to do the setup and process. And so this, it fit like a glove, and this is showing the processing here with a little bit of pink opaque and the processing pins. And that patient's actually coming on Monday to insert, so I'm really excited about that. But the system, I think, is really nice. A couple of future ideas for removable, for immediate dentures. So I really don't like grinding. I like the digital dentures, right? But one thing about me is I'm going to do, as a clinician, and with so many hours in the day, I'm going to do whatever is the most efficient. So I think that sitting there with a printed or a milled base and then grinding off the inside of your denture teeth, especially for immediates where you don't have a lot of space sometimes to begin with, right? Because when you heal after a couple of months, you're going to have the shrinkage of the bone, right? So you have a little bit more remodeling and you have a little bit more space to work with. But on a lot of these immediates, and especially when you're doing grafting for future implant placement, you don't want to be just demolishing your bone there. So these immediate dentures will end up being pretty thin. So what I have started doing is I will do a setup on the computer, and then I will do a set the base up here, and then I'll do the teeth in a couple of different segments. So I'll do like an anterior segment and two posteriors, and then I'll set it up as a monoblock. That's one of the options that you select. You say, hey, I just want to merge everything together and generate a monoblock STL file. So when you print the monoblock, it comes out like this. It's all together in one piece. And then what you also do is you print your denture teeth as well. I use the Dentka resin, Dentka denture tooth resin. And so you print the denture teeth, and you do it all at the same time. You print the monoblock, and then what you do is you invest the monoblock. So this is how it comes out. This is just with a regular like model resin. And so you invest this, put a little bit of putty on the intaglio surface, and then you invest this. When you do your boil out, which you don't need to do, by the way, there's no wax. So you just you half flask it by pouring up your two sides to your molds, and then you just after it's done setting, you just pry it off. There's no wax, and so then you peel this out. I'll still boil a little bit just to soften this up, but then you pop out your monoblock, and then you set your printed denture teeth in the cavity, right, that's left over from that monoblock, because it's the same STL file. And then what you get whenever you process is something that looks like this, right? This is right out of the press there. So you have your denture teeth that are cut back approximately where you want them, and you have a processed record base that has the aesthetics that you're looking for, and it has the strength and the rigidity that you're looking for. And then you can go to the mouth with this and do your relines. So this is, I think, a really nice workaround for immediate dentures. And then another thing that I think is cool is the partial designs. So I've just started doing my own partial designs. One of the reasons for that is because of this here. There's so many different, and if you go to like Exocad and start typing in, partial design videos, those people in Europe go crazy with this kind of stuff. And so what I did here is I didn't have very much space for like a traditional mesh or a traditional, like a little wire rot that goes up. And so for a tooth, so what I did was here, I just incorporated these teeth. I did the wax up digitally, cut it back a millimeter and a half on the computer, and then I actually incorporated the teeth cut back. They were Pontics on the software. I cut them back and incorporated that into the framework and printed all in one piece. So when this comes in, what I'm going to do is I'm just going to aerobrade, put some Monobond Plus primer, put some white opaque, and then just layer some composite on top. And those are my teeth. So it's going to be a little bit stronger than having all that. Y'all have seen anterior RPDs where things just break, right? Because it's so thin. And so this would be one way to avoid that. Also doing splints. Splints I used to hate making. Now I love them. I think somebody was saying, Eugene was saying yesterday, like when he does his duplicated dentures and splint resin, just covered head to toe, I'm right there with you guys, right? And so this material here, you can design these on the computer, and this material that I like to use, I've tried a couple of different resins, and the Key Splint Soft is really like top notch. And so that's a really nice resin to use for splints. It takes a long time to cure. I use a Moonray S that has the correct settings for the Key Splint Soft. And it, because I tried this just doing a regular printer setting, just like a model resin setting, and an hour didn't work. So I actually did the research. I looked into it And it's like, hey, yeah, you got to have this special setting in the Rayware, which is the Sprint Ray software. And it took like 4 hours to print, but that's fine because it comes out and it's super clean and they fit like gloves. And then they actually have a little bit of softness to them in the mouth at ambient temperatures. And so they go in, they feel a little tight for like a minute, and then it's like, it's perfect. So I'm really excited about KeySplint Soft. So let's talk a little bit about, I'm going to switch gears and talk about some fixed cases. And in my practice, I'm almost exclusively using the Zircad Prime. I really like the product. There's just a couple of situations where I won't use it, and that's basically for hybrids, because I think the puck sizes have been slow to arrive, where the puck sizes are as thick as you want them for hybrid cases. But the Zircad Prime is really just a game changer. So, and the paradigm used to be that you couldn't, you could tell zirconia. You could tell a zirconia apart from like a lithium to silicate. But whenever I get these cases back and glaze and stain them, these are all monolithic here, you can't tell what's zirconia, you can't tell what's Emax. Can't tell in the photos, you're not going to be able to tell in the mouth. So in the case on the left, on that patient on the left there, bruxing patient, right? So you have a lot of parafunctional habit. The contraindication to Emax is listed twice on the IFU for Emax. What's the contraindication? Bruxism. So I will still do some Emax in the anterior if I'm doing partial coverage. And the reason for that is because I don't want to prep these teeth down all the way. What I do is I'll open the patient up vertical wise. In the anterior, I want to have a millimeter, millimeter and a half for restorative space. And that's my prep finish line. Like when this lady came in, I didn't prep the incisal surface of her teeth at all. I just did a little bit of a chamfer on the facial, a little bit of reduction for prosthetic space, and that was it. And so that was Emax because I didn't want to prep a full coverage crown because of those destructive occlusal forces. But everywhere else is monolithic zirconia. And then the same thing on this patient as well. This was a one arch case, so I just did like, I think a single crown here and maybe a single crown there on the maxilla. And then I redid and refreshed all of the dentistry on the mandibular arch here. And then on this patient, this was just a traditional full mouth rehab. So this was the same situation. A couple of veneers on the mandibular arch, 23 to 26, and then everywhere else was monolithic zirconia. And you can't tell the difference between the Emax and the Zircad. So Zircad you can use for singles, you can use it for implant singles, you can use it for FDPs or implant FDPs, and you can use it for veneers. So and so I think for some people the alarm bells are ringing. Veneers, you can't bond to it. You can't bond zirconia. That used to be true because we didn't understand the material properties, right? We used to think you could acid etch it with hydrofluoric acid like Emax. No, you have to treat it specially. This is a systematic review that was done a couple years ago. Excellent systematic review, excellent shear bond strength to zirconia using a couple of different things. Rockatech is the best. That's the tribochemical coating, right? Silica based. That's the best. But if you don't have Rockatech, the best alternative is to air abrade and use or airborne particle abrasion, APA. These, I think, top two articles there. And then using some silane. And so they tried with lasers, a couple different types of lasers. They didn't really, it actually was worse if they used a laser. But basically, particle air abrasion and, just little aluminum oxide and some Monobond Plus, and these are bondable. So you can make, and you can predictably bond zirconia veneers. What situation would you be doing that in? Full coverage crowns, right, and a veneer, something like that, in order to match the optical properties. You still have some optical properties sometimes with different zirconias, especially if you're matching like an old PFM or something. You have some situations where you want to do a zirconia veneer, and you can't do Emacs, right? So, but if I'm doing, a couple of different crowns, if I'm doing a crown and then some veneers, I just want to keep it all the same. So that's when I use the ZirCAD Prime. And then to bond to it, you want to use something like Monobond Plus. This is basically pixie dust in my practice. My assistant knows if I'm going to the mouth, trying to bond something on using the cement that I use, a self-adhesive cement, they should better have the Monobond Plus. In the laboratory, anytime I'm cementing something like with the multi-link hybrid, for abutments to zirconia, as long as it needs to contain MDP, so you need to look at the ingredients list. It has to contain MDP for zirconia. And Monobond Plus has everything. It bonds to plastic, it bonds to PMMA, it bonds to composite, it bonds to porcelain, it bonds to metal, and it bonds to zirconia. So you don't need to have a bunch of metal primers, composite primers. You don't have to have a bunch of stuff. You need Monobond Plus. There's an original Monobond. Monobond Plus has the MDP in it. I like to use DES abutments, if any of y'all are familiar with DES, because their tie bases come pre-abraded, right? So and I see this is a huge lab error, is patient comes in, they have, hey, my crown came off my implant. Oh, okay, you look at the crown has cement on it because the zirconia was treated correctly, but you look in the mouth and the tie base is shiny. So when you make your tie bases, when you're bonding on your implant crowns to tie bases, particle air braid them, clean them, use Monobond Plus or a primer, silane agent, and then you'll be fine. So but DES, they come gold colored and they come pre-abraded. So all you have to do on these is just use a little bit of Monobond, put some Teflon in the access channels, and then you're ready to go. Any questions on that, by the way, on this slide? Okay. So this was the situation here. This was an excellent case. This was actually before ZirCAD Prime came out. This was just with regular ZirCAD LT. So this gentleman had 2 implants placed by a good friend of mine, John Wilson, who's a periodontist in Dallas. And he came to see me. Now, this patient's anatomy was a little bit tricky. Whenever I did the scans and got him ready for the restoration, my access channels were too far facial here. And so these were Straumann implants. And Straumann at the time did not have an angled screw channel. So on 3Shape, and this is when I was using 3Shape, which I'm a complete convert to Exocad because it's so much easier and the open architecture is so much easier to work with than 3Shape. But on 3Shape, I had fits. I spent days trying to design this case using custom abutments, using tie bases with like a double structure. I mean, it was a nightmare. But what I did was I had this patient come back in, and this is what we talked about yesterday with the scan bodies. I said, hey, let me try this different system. And so I put the DES scan bodies on, scanned them up, and then within and so in Exocad, it's a little bit different, but in 3Shape, it's actually not like a joystick ball, and you pull it and you drop it. That's where the screw access channel will be. Very easy, very simple, very clean. Some systems with angled screw channels, you have to orient the scan body, right? If it has a flat edge, you have to orient. Keystone is like this. You orient the flat edge where you want that angle correction tie base to go. So you have to know, like, or the dentist has to know where, if they're doing a full digital workflow, they have to know that if they want to angle correct to the lingual, they have to put that flat edge to the lingual. That's what the tie bases that come with a chimney that's taller on one side and then it flattens out, right? Those a little bit trickier. DES tie bases, angle correction tie bases, those are a little bit easier because it doesn't matter because they're flat on the top, so you can angle correct any way you want to go and it doesn't matter. You don't have to orient the scan body a specific way. Also with DES, you can get engaging or non-engaging tie bases. So you can angle correct on a bridge, right? With non-engaging tie bases, you don't have to use like the ASC abutment from Nobel. And so I do all the glazing and staining in my practice. So this was the finished workpiece, and the patient was very happy with that. Yes, sir. That's a stain. That's a stain. Yeah, that's the nice thing nowadays. Like, and I have 4 or 5 bottles of the Ivoclar, the gingival porcelain, right? Um, haven't even opened them because the stains look so good now. Yeah, especially and you couldn't do that, right? With metal ceramic, you couldn't do this. Yeah. Oh yeah, I do all my own glazing and staining. Yeah, but you couldn't do this with metal ceramic. The zirconia it's a nice blank canvas, right? It's like painting on a canvas versus painting on a piece of sheet metal. Yeah, yeah, exactly. I'll actually show that. I think here in just a second. Yeah, but excellent. This was a very dear friend of mine's mother. She'd had 2 implants placed, and it was strategic. 2 implants placed by John Wilson, and for singles, with the intention of later, and she had bone for it, the intention of later placing a couple of posterior implants and doing a 3-unit bridge. And so on this particular, so she came actually down to see me after, in about 6 or 8 months. She said, "Hey, I'm ready." I thought it was going to be like 2 or 3 years. So I actually made her these crowns. Okay, let me know 2 or 3 years. She came down like 2 months later or 3 months later. "Hey, I'm ready for my posterior implants." Okay. So I did the cone beam CT, printed the guide, and then this is actually the day of surgery after the placement, was on the slide on the right. And so this was all flapless surgery here. So it's very clean, almost zero discomfort afterwards. I think the hardest thing for the patient here was the palatal anesthesia. It's kind of sore for a couple days afterwards, but she healed up really nicely. And then what I did was I took the implant crowns off, did fixture level impressions, and designed everything in Exocad. And then I printed the provisionals. So this is with the crown and bridge resin from NextDent. I just bought the crown and bridge resin from Dentka. But a crown and bridge resin, this is basically a microfilled hybrid composite that you cure, and it cures on the print bed. These are pretty durable. I would rate them, to be honest, I would rate them between like a Bisacryl, right, like Integrity or ProTemp, and a milled PMMA. They're not, and they say on the website, just like conventional acrylic. Not quite. But they're a very good medium-term temporary. I print my hybrids in this as well. A little bit better because of the thickness of the hybrids. They don't typically break unless the patient eats a chicken bone. And you tell them they're not supposed to be eating chicken bones until they get the final prosthesis. But anyway, this was Zircad Prime, 2 non-engaging abutments, DES, angle correction of 0, like we talked about yesterday, like was said yesterday by Chris. Just do the same tie bases, but just don't angle correct it. What's the point of keeping duplicate inventory for straight cases and then angled cases? Just do it all angled, but do an angle of 0. That's what I did here. Angle correction of 0, DES tie bases, Monobond Plus, the multi-link hybrid, Zircad Prime, a little bit of gingival staining here, and a Emax glaze on top of the floor, right? The fluorescent Emax glaze on top. That's it. Polished on the occlusals. The reason, and I did a little bit of staining here, but I didn't glaze on top of that. I polished all of this. And the reason why you want to polish the zirconia on the occlusal surface is because that's the kindest to the opposing dentition. And then also on the gingival margins, on the proximals and everything, I don't like glazing on proximals because I've developed in my software exactly the contact I want. You do a 0 millimeter, like 0.0 millimeter contact in Exocad with or in 3Shape with your designs, and you just polish that, it's going to be floss perfect. Your doctor will call you up and say, whatever you did, keep doing it, because you will. I almost on some of these cases that I'll show you, the handpiece cassette and the bird block is still in the sterilization pouch after the insertion on a full mouth case, because your contacts are so nice whenever you just polish them. So I polish occlusals and proximals and the linguals, of course, because polished zirconia has been shown to be the friendliest to the gingival tissue, right? So it's a little bit friendlier. And what I mean by friendlier is bleeding indices and stuff like that, and probing depths, just because nothing sticks to it. Nothing sticks to polished zirconia. Glazing, and this is kind of a side tangent, I'll get off my tangent, but glazing on zirconia has been shown to eventually delaminate. So glazing on zirconia will eventually, when it's been in the mouth for years, it will eventually, and this is with an in vitro study, I'd have to dig up the literature, but the problem is after artificial aging, zirconia glaze will eventually delaminate. I think that can be mitigated by particle abrading the zirconia before you glaze it, but that defeats the purpose. You might as well just polish it. So whenever I'm doing glazing and staining, I'll actually just do a really light particle abrasion on the facial and then go in and glaze that and then polish everywhere else. Next situation, my beloved grandmother, actually. So she came in, she needed an implant on her first molar. We took the tooth out, did the implant, and then she came back to me a couple years later. She had some amorphous pain, couldn't really, it was hard to point it out on her number 4 and number 5. No canal on number 5, sent her to the endodontist. The endodontist did RCT therapy on 4 and 5. She made her own canal, the endodontist did, on number 5. Okay, we'll see how that works. I had tried to do crowns here first. I did a crown on number 5 first. And I'll say this as an aside too. It's interesting. This was with a 5 mole zirconia that I was trying out. And it's funny, when the endodontist did the access through the crown shattered. So there's something about 5Y, 5 yttria stabilized zirconia that it just it shatters. But if you look at like Gordon Christensen on Clinician's Report, 3 mole zirconia is a little bit better when it comes to just like shattering when you're doing endo access. And there's been some recent literature that I have seen, but I haven't internalized it, that actually supports that. But anyway, we did the endo, it didn't work. So she came back in, and I did flapless placement. So I took those 2 teeth out, did flapless placement, buried the implant, did a little grafting on top of it, and then came back in 3 months later, did the uncovery, did the scans at the time of uncovery. So I took this crown off, did the scans, and then designed it in the computer with a Trio scanner, which is what I use. You can have a color mapping scheme, right? You can pick and shoot. You can pick the color mapping. One of my co-residents, she did her master's thesis on the accuracy of the Trio system with color matching. For value, it's perfect. For chroma, not quite there. It's like 75% accurate for chroma, but for value matching, it's almost perfect. And I think it's probably even better. That was with like a Trios 2, and this is the Trios 3. And I mean, you can pick and choose where you want it to do your color mapping, so which is really nice. If you have doctors that use the Trios, you can ask them, hey, like, can you send over something like this, where they do shade mapping, a couple different spots, and then that'll really help you guys out. Anyway, generate the STL file, design the crowns or the bridge, the FTP. And then what I do is I send out, so I don't have a mill. I forgot to mention that earlier. I don't have $250,000 or $80,000 to just spend on a mill, right? So what I do is I have my scanner, I have a lab scanner and a intraoral scanner. I have the CAD software, which is ExaCAD, and then I do my designs, and then I send out to the milling center, to house milling, which is right here in Carrollton, all of our name badges, right? And so that's been excellent. The turnaround time is about 2 to 3 days for non-implant based, and if you have a custom abutment or something that you need mill, it's about a week turnaround. And that's where I send out everything. So they have the Prime, they have Emacs. Those are basically the two that I go straight. I have this page bookmarked, and so I'll send that out. What you can do is you can also you can have them do the designs. You can have them do the glazing and staining. You can have them do, you pick and choose what part of the restorative workflow that you want them to do. And then you either assemble everything yourself at your practice. If it's an implant-based case, you do the glazing and staining yourself. You do a little bit of stacking yourself, whatever you want to do. You can just pick and choose what you want to do. And they have pretty much everything. They'll print models. They'll do your zirconia hybrids where they can design it and do the gingival, and then send it back, for you to finish it up. So I really like them, and they're really they call me up all the time. Hey, did you mean to submit this case twice? So we'll cancel the duplicate for you, right? So they're really good. So I can't plug them enough. So, but anyway, that's where I send all my zirconia, and then like I said, they'll do whatever you want them to do. You acquire the data, and then you can either design in-house or you can send it out, export the design for them for milling and sintering, or that you can have them finish the whole thing. Whenever I talk to doctors about this, they're usually more online of, hey, I'm just going to send them the whole thing, have them glaze and stain it and send it back. Or a lot of the guys that have like a Cerac machine and a little speed fire or something, they'll just do like a spray glaze and then seed it. I'm not really too big of a fan of spray glazes, but that's what some guys are doing. Okay, so that's the finished workpiece there, and that's in the mount. I wanted to put this next one on here as a kind of like a, hey, this is how you can do it. This is a cancer patient. He had prostate cancer, but they weren't sure how advanced and where all he needed radiation, so they just blasted his whole body, basically. And I don't know why, but that's what he came in with. So this guy actually was a really high up. He was retired at this point, but he was really high up in some early telecom companies. I mean, like smarter than I am, like by far. Like I felt just totally incompetent, intelligence-wise, in this man's presence. But he had, this horrible oral condition, and so he didn't want anything removable. He didn't want anything removable during the interim time. On the maxilla, he had these ginormous exostoses that you can kind of see here. I mean, we're talking caverns that you can get your finger up and over. So the surgery to take those off would have been, to do a traditional hybrid, would have been just atrocious. And so what we elected for is just doing crown and bridge. So I did crown and bridge on the maxilla and did a traditional metal resin hybrid on the mandible. So what we did first was I prepped him. I just had him in and prepped all his teeth, and I did the wax up, of course, and then duplicated it, made a stent. Nowadays I would just do this all digital, print a cast, do a thermoplastic stent on that, or I would just print the temporaries. But I basically prepped him and then put a PMMA. I made a lab process PMMA temporary, put it on, and then we went for surgery. So we left these abutments here, right, in the areas that we were not going to be placing implants. So we took out some of the other teeth and placed the implants where they needed to go. For this case, first molar, first bicuspid, and canines. Canine to canine for an implant FDP is a little bit sketchy unless it's opposing something like a hybrid where you can control the occlusion to a T. So if I was to do this and it was opposing, say, like a zirconia hybrid or opposing natural dentition, I would place one more implant in the anterior. But I was okay with doing canine to canine on the implants here, and then doing segments. And so we placed the implants, grafted, let it heal, He went home with the same PMMA provisional on. We eventually started losing. There was one tooth that abscessed on him because these were all, what you do is when you have a situation like this, you close your eyes and you prep the teeth, and you just like, if there's decay left, you just don't care. You need something for this to latch onto. What I'll do sometimes in these situations is I'll do a little bit of silver diamine fluoride, which is the stuff that turns your teeth black, right? But it dries up all the caries. And so if I have a situation like something like that where we still clearly have caries left, I'll paint on a bunch of SDF, and then hopefully that gets us through the healing period. So you place the implants. Patient comes back a couple months later. You've done the hybrid surgery, so this is just really quick going through the hybrid workflow. I tried something new here. I did the conversion, and then I said, okay, well, let's just do a pickup impression and see what happens, and then go back and do. This was an experiment, so I did a verification jig after this. Don't worry, but I did the final impression with the conversion appliance in the mouth. I put guide pins in, which screw directly onto the multi-units, and then put a little wax on top, fitted a tray, highly custom tray, and then I did did a pickup impression here, just like that. So when I went to the laboratory, I poured that up, and then I made a bite record as soon as he came in, right? So I made a bite record as soon as he came in. I poured that up. I waited for the stone to set. I pulled the tray, and then I had the temporary still on the cast, and so I just put the bite record on and mounted up. So he stayed for about an hour or whatever, and then I gave him the temporary back, and then the next appointment I was ready to go for the wax Triant. So these are with Finara's teeth. Finara's teeth, you have to be careful. You can't grind all the way through. There's a PMMA layer on the lingual of those teeth. I learned the hard way several times. You cannot grind all the way through the PMMA layer to get to the micro, like composite layer, which makes them look so nice. You have to leave some PMMA. So if you're grinding the crud out of these teeth, you should probably use like a DCL, like a blue line tooth. So that's just the wax up there. And made the bar, anodized the bar when I processed. This is old hat to many of you. Wherever you don't have to grind through the teeth, you can do that later and after. So I processed, and then you get like Nobel actually makes a tool that you can put on your copings here on your bar, and it has a reamer, and you can just ream all the way through. Have y'all seen that? Right? Used to, back in the day, we'd use like a drill for doing a post spaced, like a parapost in the mouth. But now you can get something that attaches to the coping, and then it has a hole in it that you can just ream all the way through, and you ream it up through the occlusal surface, and there's just a little tiny hole there that you can then go in with like a round burr and open up. Those are really like crucial when you're doing something like this. So that's showing the final product there. And then on the maxilla, he comes back in, pretty beaten up at this point, but ready to go for the uncovery. So we did the uncovery and then went to place the temp copings. So I reamed out the provisional before I extracted the teeth, right? So the teeth are still in. Do the uncovery, put the temp copings on, non-engaging temp copings, and then pick them up. You don't have to cut, you can cut these in the lab after you pick them up. You don't have to cut all the cylinders before you pick it up. You can cut these later just with a greenstone. And then while you're modifying, so basically what you do is you modify, right? So you take this back to the lab, you fill in the ponic spaces where your old teeth were, because the surgeon's in there right now taking the rest of the teeth out because you're indexed, right? Those are your indexing points. You fill in the where the preps were, where the abutments were, and make those into ponics. And now your former ponics are now where your abutments are. So that's called a flip-flop or a serial extraction protocol. Works really nice if you don't want to have something that's removable like a flipper in the mouth. When you're doing grafting, when you're doing implant placement, a flipper will destroy bone. And Essex is better, but I mean, how many patients are willing to put up with like a full arch Essex retainer, right? Especially when there's like 2 teeth left. So doing something like this is a little bit better, in my opinion. So patient comes in. We had a sinus blowout here, so we had to wait actually for this to heal up a little bit more. So we have our bicuspid implant in on the number 5 position for the posterior FDP. So he comes in, I sectioned, made my final impression. This is with the luting them into place with the floss, cutting the floss, reluting, making the final impression. For cross-mounting purposes, I would do this digitally. I'm going to skip actually a couple of cases and show you a digital cross-mounting that I do now. But I would, I sectioned these and did some segments. And then for the actual bite registration, Straumann makes a nice bite record tab. But, for these, if you're trying to get a good bite record in the posterior, kind of hard, right? Because you need some tripoding points. So actually, one way to do this, if you need to get a good like bite record, is to place a really tall healing abutment on the implant, and then use that as like a prep for a bite record. So that works really nicely for that purpose there. If you need something to index off of, you take all this to the lab. I wouldn't do this nowadays. I would do this all digitally. And then you design your FDPs. I did this with a cutback, but I eventually ditched this and just did monolithic in the anterior and did a little cutback on the posterior FDP in order to have a little bit of fun with the Emax ceram. So that's cut back. This is with Nobel ASCs. That's cut back there. And then that's ready to go into the mouth. One side note about ASCs, do not cement them in the lab. They're not meant to be cemented. They're meant to be clamped with the screw force, right? There's no prep pipe on ASCs. So you have to, you clamp everything together with the screw, just as an FYI. And so that's your final product. Remember, we had to wait for a implant to heal back here. But that's the final look there. And then this is the final FTP. So we actually ended up placing an implant in the number 2 position, and this is with the Zircad Prime. I didn't have access to Zircad Prime at that point on the other work pieces, but this is with Zircad Prime, like a little bit of blue at the incisal or the cuspal edges, and a little bit of pink in the interproximals with those non-engaging abutments, and it's just perfect. So this was really nice and ended the case really nicely. You can see there. This guy, I'll probably skip this, but I'll just say that he came in as a train wreck. He had a flipper and like some temporary on. And so I didn't want to buy all of the impression copings for Keystone. That's what the implants are. So I printed a temporary that just had access holes in the occlusal, and I just cut the copings and just picked up those in the mouth, and that's how he left. And then when he was ready to come back for the final restoration, I did the scan bodies in the mouth. What I did on this case that was kind of fun was I did a digital cross mount. So what you do is you have your final impression in the lab. You have a scan of that. You have a scan of the temporaries in the mouth. And then you have a bite scan of the temporaries. And so what that actually allows you to do is you can superimpose your STL files. So the only bite record that you take for the whole case is, hey, patient, bite down for me. So the patient bites, you take a bite record of that, you can superimpose your STL files, and that gives you your digital cross mounting. Don't have to do any analog mounting at all. And so this one was really nice. It turned out nice. He had bone loss around some of the implants. They'd only been in for like 2 years. I think some health factors in behind the scenes, but this was basically just a little bit of glaze and on the facial and polishing everywhere else, and that was it. So this one turned out really nice. This one too, on this implant here, this is what I was saying earlier on Keystone. Whenever you have your scan flags, you have to make sure to orient them in the correct position for where you want that angle correction to be. For my photography, a final plug here, photography, and I'm going to go over like 1 minute, but photography, I like to use, these are all very inexpensive. I've experimented with everything photography-wise. Strobes, big strobes, small strobes, dual point flashes, ring flashes. This to me is actually the best, and it's not expensive at all. It's a donut flash. So you put just a regular any old flash in on your camera, and then it inserts into the back here, and it gives you a really, really nice flash here that doesn't have a lot of hard light and hard glare. That's how I got all of these pictures here. So I can't plug enough on these this type of flash. It works really nicely. I'm going to show one more fixed case on a full mouth, and then I am going to be done. This gentleman came to see me. He was I was like the fourth opinion. He'd gone to 2 different Clear Choices, Arch Point, Clear Choice. He'd gone to a general dentist that my wife taught. And the general dentist referred him to me, hey, like, can you do his all-on-4 for him? And so I said, where do we need the all-on-4? When you take a look at this guy's roots and his teeth, the teeth are actually fine. It's just he's a wear patient. And so I am staging this gentleman I did the maxilla first. But when you look at a situation like this, a lot of times people's first thoughts are all-on-4, double arch all-on-4. Get rid of them, wipe them clean, start from scratch. This guy, he had all of his teeth. He was missing like 1 molar. Number 14 was missing. 15 too, but he was missing basically a first molar, and that was it. He had a full complement of teeth. And so what I did was I worked him up for some crown lengthening and did that on the computer. So what I did was I said, and this goes back to occlusal vertical dimension. What I did was I opened him up. I did with the tab there and said, hey, where do I need to go? I need to open him up a couple millimeters, and then also I need to go north as well. My gingival zeniths are all kind of messed up, so I need to go north. So I was able to compute the size of tooth that I wanted, and then I printed a cast, sent that to the periodontist with the CEJs cut out of just like a 0.8 millimeter thick BioAcryl, right, thermoplastic sheet, and then she was able to do the crown lengthening for me. Patient comes back, crown lengthening's done. He's been healing up for about 3 months, chomping at the bit to get started. So what I do is I come back with the same stent, same wax up cast, just do like a little soft, like a temporary coping, right? And so what I do is when I prep teeth, I have no clue. Like patient comes in like this, I have no clue where to prep. And so what I do is I fill up a thermoplastic matrix with bisacryl, take that to the mouth, take it off, and then it's like, hey, this is like prepping a typodont at this point. So I come back in here, I do my occlusal reductions, I do my incisal reductions, I do my axial reductions, and then I flick off all of the bisacryl and just connect the dots. I'm smoothing things up, I'm connecting my axial reductions, I'm refining my preps, and that's it. You don't have to keep putting the stent on and like checking, poking holes in it with a perio probe, right, to see what your reduction is. You use your bisacryl in your eyes to do your reductions. So we get the preliminary preps done, and what I do is I have my wax up vertical saved. This is the vertical dimension in the computer. I use that as my bite record with the preps. And then I go into my lab and I drink a coffee. I scan them up, and then I go drink a coffee, have a break, patient takes a nap, and I have this takes me about probably 10 minutes to design the temporaries. I design them in usually 4 segments. So I'll do posterior, posterior, and then canine to central, central to canine. And then as soon as these are off the print bed, wash them in alcohol, cure them for about 10 minutes, and then they're ready to go in the mouth. So the patient leaves with this. Once the patient's happy with the temporaries, and sometimes I'll do 2 sets of temporaries. Hey, hey, doctor, can you lengthen this? Can you shorten this? Not a problem. Go back into Exocad, press the reprint button, and out pops your new temporaries, right? And so I'll do stuff like that all the time. And then what I do is I take a new bite record, take a scan of my maxillary provisionals, take a new bite record there, and I can actually superimpose everything all together at my final vertical dimension. And then I'm ready to proceed with the finish out. And this is with Zircad Prime. The laterals are a little longer. The periodontist actually begged the patient to come back and let her do a little bit more here. He's like, I don't care. So, but I made him look really nice. And this is just with Zircad Prime with a little bit of glaze on the facial. And that's pretty much it. So you can see the before and after. This patient was ready for a double arch hybrid. They already had the dentures made, but it's like, no, like let's give the teeth a chance. But anyway, that's all I have. Any questions on what I've gone through on the fixed side or the removable side or the implant side? No. Hmm? Oh yeah. On this, yeah. And like I said, the periodontist was begging to do a little bit more touch up on 8 and 9. Like I said, hey, like let me laser this a little bit. Let me just go in with a diode laser and sculpt that a little bit. The patient was like, I don't care. It's like, but if it was me, like my mouth, I would definitely. Another thing, and that brings up just a really quick point too. With the glazes and the stains nowadays, if you have a situation like that where your apical position is set, just put some pink on it. Just do a little bit of pink. You can do pink stain on monolithic zirconia or Emax, and it doesn't add any depth. You don't have to stack anything. You can do that on natural teeth or on implants. It would be the Avocolor or the Mio. I've used both, and they're both like really excellent. Yeah. You had a question here too. Yeah. But regardless of the system I use, the Emax glaze with the floor, Emax glaze floor is the best. Right. Yeah. It's the temperatures are compatible on those. So you can do the Mio first and then do the Emax glaze after. Yeah. Okay. Oh, it peeled? You might want to air braid the zirconia then. Yeah. 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 All right. Well, thank you guys.
If you need any information about the product that Dr. Bowie spoke about from Ivoclar, if you haven't visited our booth yet, please do so. We're here for you. And thank you for your support for
No,
the DLAT, and this is just a small thing
Oh,
to
perfect.
enjoy
Oh, perfect. All right. Thank
from
you.
just to say thanks for
Thank you.
being with us.
Thank you. Thank
So,
y'all. Thank y'all for having me.
have a good day.
All right. Thank you. Thank you.
Okay, guys, we're going to take about a 10, maybe